All right, welcome everyone. Thank you for joining today for APRV. What is it really? And I think one of the most beautiful things about APRV is that I love talking about it because I think a lot of times we're not that familiar with what it is, what it means, why we do it. And I think it's really important to remember that when you're at the bedside, either as a provider or as a bedside nurse, and you're struggling to improve your patient's ratio of oxygenation, and really your patient is deteriorating or pre-deterioration with the clues that you're using a significant amount of oxygen, an FiO2 of greater than 60%, and a PEEP that is higher than 10 or 12, should always consider the possibility of APRV. So APRV stands for airway pressure release ventilation, and it's primarily a mode that is utilized for patients who have refractory hypoxia in ARDS. So I'm going to just start with a case. This is a 63-year-old man, Cabbage, and his post-op course on day one, he started on inotrope. He had very low urine output, about 0.25 mLs per kg per hour. He was following, of course, post-op Cabbage pathway, which is get them extubated really, really quickly. But what ended up happening is he became very volume overload. He had a lot of fluid creep out into the interstitium, and his creatinine tripled and his GFR dropped below 50. So first he got Lasix, and then he got more Lasix, and then he got placed on CRRT. But by the time he was on CRRT, it was clear that he had diffuse bilateral infiltrates. He's on a controlled form of mechanical ventilation, assist control, 650 cc's of tidal volume. And let me just make sure everybody's muted. Okay, so he's at 100% FiO2. His PEEP was 8 and then 10 and then 14, but his PaO2 is 80. Now, just remember, whenever we look at oxygenation, we basically say, what is your PO2 divided by your FiO2 in the decimal? So in this case, this is easy, 80 divided by 1. That's known as the P to F ratio. And that indicates to us that he has severe ARDS. Now, PEEP is part of that, that framework as well. He's on a PEEP of 10. You only have to be on PEEP of 5 or greater and have a P to F ratio less than 150 to be considered as having very severe ARDS. And indeed, he has severe ARDS. So one of the things that I really want to introduce to you is, when do you think about a form of ventilatory support that might be a little different than what you do standardly? And in this case, we're talking about APRV, but it might also be something that you're thinking about in your area or with your physicians. That might be pressure control inverse ratio ventilation. So you really have 3 basic choices here. Can I go up on PEEP more? We're at 14. Can I go higher? Yes, of course you can. Do you want to? That's really the question. Do I want to prolong the I time of the patient, meaning that you're going to flow the gas slowly and try to open the lung up over a longer period of time? That's known as pressure control inverse ratio ventilation. Hi, my friends. If you could all please make sure that you're muted, that would be very helpful.
Very helpful. Very helpful. Very helpful.
Okay. I can see that not everybody is muted, but I don't have the ability to mute everybody. But if you can do it, that would be awesome. Thank you so much, because we get a lot of feedback. All right, so really important when we're thinking about this relationship is that we're entitling this patient as having refractory hypoxemia. We're using a relatively high PEEP, we're using a very high FiO2, and our patient's oxygenation is not strategically improving. Now, that doesn't mean you're not happy that you got them to 80 or 90, but you're using a lot of PEEP and you're using a high FiO2 in order to make that happen. And we know that that indicates to us that the lung is not open, it's not recruited. So we're going to think about lung recruitment maneuvers, and in particular APRV, in patients who meet some basic criteria. So bilateral infiltrates, that the normal P to F ratio is around 300, but if you've got somebody who's at 150 or below, and their P to F ratio, that just means the portion of gas I gave the patient that gets into the blood, I'm going to consider another alternative type of ventilatory support. Also, plateau pressure is greater than 30. Now, I'm hoping that everybody here on this call is familiar with plateau pressures, but if you're not, don't worry, because I'm going to show you what they are, how we measure them, how we know what's right. But plateau pressure should always be greater than 30. That's actually something we create when we press a button called inspiratory hold, and the ventilator looks at peak gas flow, and then it shuts the exhalation valves. And you're looking at the amount of pressure that is generated when that gas is delivered across the functional lung surface. In addition to that, you have to be sure that your patient does not have a significant left ventricular dysfunction. Now, historically, we talked about that with the wedge pressure or PAOP pressures less than 18, but really we can make this strategic determination by echocardiogram, by your patient's history. We just want to rule out that the cause of your infiltrates is not left ventricular failure. And that's the most important thing. LV failure with aggressive pulmonary edema will look very similar to ARDS in terms of the chest x-ray. So in other words, this is really persistent ARDS. Okay, so as I said, one of the most important criteria here is about measuring pressures. And we look at 3 pressures. They're really, really important to us when we're talking about APRV or lung recruitment. The first pressure is the peak inspiratory pressure. That is the peak pressure that is reached when gas is being delivered from the ventilator into the patient, down the ET tube and into the lung. Now that incorporates all the resistance of the airways and of the conducting airways, the ET tube and the alveolus. So it isn't really particular for alveolar recruitment. It is a global indicator of the compliance of the airways and the alveoli and the thoracic cage in relationship to the gas flow. So there's a lot of things that can affect it. You can have a mucus plug, you can have inflammatory airways, you can have edema, you could have just need to be suctioned will actually cause your peak inspiratory pressure to go up. So it's a nice reminder, the alarm that goes off from the ventilator is a nice reminder that something's going on, but it's not specific to the lung recruitment, the gas sacs, which are the main surface that we're concerned about in ventilation. Second to that, I'm actually going to skip to the last one, the mean airway pressure. The mean airway pressure, similar in theory to mean arterial pressure. The mean airway pressure is the constant pressure that is maintained throughout the airway circuit, with both inspiration and exhalation being incorporated. So remember, on inspiration, you're going to have a peak inspiratory flow and a peak inspiratory pressure. And then for all the rest of the cycle, you have an exhalation pressure. Now, typically, exhalation pressure is going to be affected by the amount of PEEP that we've applied to the patient. So if I breathe in for 0.6 seconds and then I'm in an exhalation cycle for 4.4 seconds, then the majority of the effect of that pressure is what that pressure is during the exhale time. And for us, when we're talking about ventilation, that's typically peak inspiratory pressure and PEEP, and looking at the time spent in both. That's what gives you the mean airway pressure. Now, that was a great big explanation with very few words on the slide. So again, here's what's most important about mean airway pressure. Mean airway pressure is a reflection of the pressure that is required to maintain your lung opening. Now, that's really important, because when we're making decisions about alternative ventilatory support like APRV, pressure control inverse, or maybe even in your institution, high frequency oscillation, we're going to look at that mean airway pressure, because that's going to give us advice as to what we have to apply to open our patient's lung. And when I say open the lung, I'm talking about opening the alveoli so that the gas the patient breathes gets into those little gas units and then can transpose into the blood. And then finally, the plateau pressure. Plateau pressure is, remember, as I mentioned before, we press an inspiratory hold button on the ventilator. The gas has gone into the patient, and when we press inspiratory hold, all the exhalation valves close. So I've trapped that gas in the lung, and it's delivered across the lung surface. Now, if I have a great big lung surface, holding that gas in the lung will exert very little pressure. And that's a person who's got a nice open lung. But we're talking about individuals who have lost lung function because of their exudate and because of destruction of the alveolus. They have ARDS. So their lung is not the lung of a 6'2" man. Their lung is the lung of a 10-pound baby because they don't have functional lung surface. So when I put that gas into their lung, that yielding pressure is very high because the lung compartment has gotten much, much smaller. So when we talk about this, it's really important to appreciate that when we deliver gas into the lung, that's called a dynamic pressure. That dynamic pressure is an indicator of the ET tube, the conducting airways, the alveoli, and the thoracic cage. When I press that inspiratory hold button, closing the exhalation valves, I've trapped the gas in the lung, and that is a reflection of what we call static pressure. And it's also alveolar pressure. How much pressure is generated when we're trying to open the alveoli? Now, if you have nice, healthy alveoli, the pressure that is generated when you're flowing gas into them is going to be very low. But if you have collapsed alveoli, the pressure that is generated when we press that inspiratory hold button is going to be very high. We call that P plateau pressure. That is the actual pressure that we must overcome to open the lung. Okay, now that's really important because if I have a patient who has a P plateau of 30, PEEP of 10 is not going to open the lung. I have to get to 30 or perhaps even above to actually open the lung. So we use P plateau or mean airway pressure plus 4 to determine the lung opening pressure. And that's critically important when we're talking about this style of ventilatory support, APRV. We are going to try to apply a critical opening pressure, popping the alveoli open and maintaining the alveoli open. So all the patient has to do is breathe a tidal volume breath of about 1.5 cc's per kg of air, a tiny, tiny hummingbird breath because the lung is open. Now, this is a really important concept for us. Again, some of us might be writing the orders. We might be managing the ventilatory support of our patients, but the majority of us are bedside nurses who are evaluating patients. We're getting these alarms. We're getting high pressure alarms. Patient is not oxygenating. He's on a lot of FiO2, and everybody is really nervous about, well, he's on a PEEP of 8. Should we put him up to 10? But if we look at a plateau pressure and the plateau pressure is 30, you're wasting valuable time being so frightened about going up on PEEP or applying another strategy to open the lung. And we're going to waste a lot of time doing it that way. So that's one of the reasons we come together to talk about this is how do we actually advocate here? Well, first of all, ask your therapist or you yourself, only with approval, press that inspiratory hold button. You just to press it, take your hand off. The vent will do the rest, and it will display what the P plateau pressure is. And if our P plateau is greater than 30, that typically means that we've got gas in the lung, but it's trying to go into 5 alveoli instead of 5 million alveoli. That means that the compartment is really tight and we have volume going into a tight compartment and we're going to yield a very high pressure. Now, normally another important component here is to recognize that the difference between the peak pressure and the peak plateau is typically 10 to 15 centimeters of water pressure or even greater. But as you lose alveolar recruitment, these two pressures actually almost equalize. All right, so let's just take a quick look. Anybody who's ever heard me speak about ventilation or blood gases or anything, I always use this basic artistic drawing. I'm the artist, that's why it's not a great drawing. To just say gas flows into the lung and you have a peak pressure, that's also known peak inspiratory pressure, PIP, peak airway pressure, PAP, or proximal airway pressure, PAP. It's all the same thing. It's P peak. That's how I'm going to refer to it. P peak pressure. P peak is the highest pressure that's achieved when gas is flowing into the lung. And remember, that incorporates the ET tube, the conducting airways, the alveoli, and the thoracic cage, okay, and the pleural pressures. So, and then we press that button with the inspiratory hold, and that is going to give us our P plateau. So P peak should always be less than 40 or 45. If it's 40 or greater, you're very concerned. Now, your high pressure alarm might be going off because your patient is tonguing their tube, they're biting their tube, they have a mucus plug, they have a lot of secretions, they have inflamed airways. But it might also be reflecting a reduction in the functional lung surface area. In other words, alveoli that are not recruited. Okay, so remember that the P peak and the way it's referred to typically on your ventilator is PIP or PAP. Okay, the P peak is the peak flow of gas rushing into that compartment and the yielding pressure. We never give patients pressure. What we're seeing is the pressure that is generated when the gas flows into the lung. And then with the inspiratory hold button, that total volume is trapped across whatever alveoli are recruited, and that gas is trapped inside. And the less alveoli you have, the higher the plateau pressure. So I always just remind everybody, again, you probably heard it before, it's just like taking your body. So let's just say you're 40-year-old post five live births. And when you were young, when you were 20, before you ever had children, you wore a size 2 jean, and now you wear a size 12 jean because your body has changed, your volume has changed, okay? Now, the other aspect, because that's really what I meant to say, is that size 2 jean, and you're a size 2 body, but your husband washed your jeans in hot water, and they are now a size -3. Your volume hasn't changed, but you have to exert a lot more pressure to get your volume into that -3 jean that shrunk in the dryer. And that's really what P plateau is. P plateau is a given tidal volume that's being delivered into a surface that once was compliant, that is now non-compliant. And that's what the plateau pressure is. Now, we would like to always have plateau pressure, less than 25 centimeters of water pressure. Anything greater than 25 indicates that you have alveolar derecruitment. So you can only measure this with a volume breath. You can't measure it with a pressure control breath, and you can't measure it on spontaneous breathing. It has to be on assist control with volume as the target, and the volume should be 8 mLs per kg or less. If you were doing a 12 ml per kg breath, you might have a very high pressure because that's just too much volume to be giving the lung. Okay, so we just look at this P plateau, and you'll see here, P plateau is 28. The dynamic compliance is 35, and the P plateau is 28. Now that's pretty high. That's a high pressure. It's greater than 25. It would give us some cause for concern. And I love this little drawing that just reminds you that when you're talking about peak inspiratory pressure, you're just looking really at trans-airway resistance, meaning the gas coming from the ventilator down the ET tube through the airways to the alveoli. But P plateau is really telling you about transthoracic pressure. And we're going to use P plateau to tell us about alveolar recruitment or alveolar derecruitment. And again, anything greater than 25 with a tidal volume breath of 8 mLs per kg or less, anything greater than 25 is going to indicate to you that you are not actually delivering gas into the alveoli. Now, it could be that you have a hemo, or you have a pneumo, or you have a fentanyl overdose and lung rigidity, but in general, high P plateau pressure indicates that the alveoli are not recruited. Now, whenever your P plat goes up, your PIP will also go up, but remember, you want to look at the difference between the two. So normally 10 to 15 centimeters water pressure between PIP and plateau, but as the lung becomes derecruited and as the alveoli are collapsing, what you're going to see is both PIP and plateau will go up, but the distance between them will narrow. And you'll know that your patient is improving when the distance between those two gets wider. that gives you a really good indication about what's occurring. So now I'm just going to show you a ventilator screen where I have done a P plateau measure. I pressed an inspiratory hold, and that inspiratory hold will be marked on your tidal volume and on your pressure as this white line, also on your flow if you've got a flow curve on your vent. So all I did was I pressed the inspiratory hold and I took my finger away and I just waited to see what the P plateau was. Now, this isn't a sick patient. They have a very nice compliant lung and their P plat was 16. I wanted to just show this to you because this is a really simple procedure. And again, you don't want to be pressing buttons on the ventilator if you don't really know what you're doing. So you make sure that you've had a discussion with your therapist. They can show it to you. They might give you permission. They might not, but you can always ask for them to do an inspiratory hold so you can look at P plat. Okay, so now we're going to go back to our guy and we're going to say, remember, he's got a PO2 of 80, he's got a PF of 80, he's on 100% FiO2. His PEEP went from 10 to 14, his P peak is 40, and his P plat is 36. Now his P peak isn't extraordinarily high, but the P plat is only 4 different, and that P plat is above 25. So that tells us in this patient in particular, we've got to do some strategic manipulation to try to open his lung or he will probably not survive. And we can't just be going up by 2 on his PEEP when in actuality, we're already seeing that his alveoli are going to need a much higher pressure to promote opening. Okay, that's going to be a really important concept for us. Okay, so now we take a look at our patient, basically. Here's his peak, 40. Here's his P plat, 36. I press that inspiratory hold button, and you can see this is a different graphic than the other graphic we looked at. This is his flow rate, and flow goes in, that's green. Let me go over here. Flow goes in, that's green. Flow goes out, that's yellow, and it returns to baseline before the next breath. But what I've done is I've created an inspiratory hold. So the gas went in, that's what the green is, and then it's held there. Okay, and you can see that down here on the pressure circuit that you see gas goes in and then it comes out and then it goes in and it's held. And his P plateau is 36. So that already has told us that this patient's really got lung dysfunction, and no wonder his PF ratio is only 80 because his alveoli are not open, they're not recruited. We always know that when P plateau is elevated that we have some concern with the openness of the lung. Johnny, if you could mute yourself, I'd appreciate it, my friend. Thank you. Okay. All right. So very good. So there's your P peak, showing you that peak pressure that you reach when the gas flows in, and P plateau, that's correlated to that flat line. And remember, green means go in, yellow means go out, white means stay. And that's what that's telling you with your ventilator. Now, that's a really important concept. And again, I want to reiterate that the concept that we're applying here is that as gas gets applied into your lung, it should move very quickly to the alveoli. But sometimes what you can see when you're looking at ventilator scalars or graphics is that the gas goes in, and then finally takes off and gets delivered into the alveoli. So right here is this kind of slow incline. And then you see this kind of angle where the gas flow in takes off, right? So you have a slow incline and then the gas flow goes in and takes off. This is called the low inflection point. Now, I'm just going to tell you that most respiratory therapists, pulmonologists, critical care specialists, have some trouble reading these scalars, and I'm not advising that you read these scalars, or I would always look at them, but what I want you to appreciate is that a lot of your breath is wasted trying to open the alveoli, and then very little of the breath is left to actually deliver gas into the alveoli when your low inflection point is high. So here we could say this is 5 and 15, and here is your low inflection point. I'm making that number up because I don't have numbers on the bottom of my graph. So I'm just saying Once you see that gas take off and move rapidly into the lung, this is known as low inflection point. And this is where your lung has become compliant. So you are opening the lung at this point. And also, if some patients have a very good scalar that you can see, this is where you've got to set PEEP. So if in your unit you say, oh, well, we use 5 of PEEP or 8 of PEEP regardless, and we have a patient whose low inflection point is 15, you're going to have a low PF ratio, and your patient is not going to have adequate resuscitation. They're going to have a high PEEP plateau pressure. As I set the PEEP higher, I'm going to actually open the lung. Now, up at the top here, what you see is this little beak. This, a lot of times people call it a duck beak. This little beak is over distension of the lung. And typically what that means is that you're giving more tidal volume than the patient needs. So that's always something we always are concerned about. It raises the peak inspiratory pressure, peak airway pressure. And where we see that narrowing, right here, that narrowing, that's telling you about regional overdistension. So what our goal is, if we were looking at this scalar, and what I want you to appreciate is just the theory here, the goal is that I want to start at lung opening. So I'm going to start at low inflection point, and I'm going to stop delivering gas at that upper inflection point. Okay, so I don't have over distension and I don't have de-recruitment. That's what's really important. I want to actually ventilate you as perfectly as I can, to actually assure that the gas I'm giving you is getting into your alveoli so it can move into your blood. So I'm going to start with the lip, low inflection point, and I'm going to consider the upper inflection point. And typically, if I wanted to look at this, I'm going to do that with my therapist, my respiratory therapist, so we can really have a good discussion about it. And unfortunately, this is an artist's rendition, and patients don't behave so artistically, and every breath can look quite different. So it takes some time to really look at these scalars and make some inferences. Our goal is to actually optimize the alveolar recruitment. This is often referred to in ARDS literature and pulmonary critical care literature as the sweet spot. The sweet spot is where you actually have recruited alveoli, and that's what your target is at all times. So this is such a fantastic visual. I'm going to just turn the sound off because I don't really want to hear this man, although he's very wonderful. This is the lung with 5 of PEEP. And now we're going to add 10 of PEEP. And what you're going to see is the lung is going to start to pop open. That's 10 of PEEP. And now we're at 15 of PEEP. And now we're at 18 of PEEP. And you can see that this was a lung that had actually had installation of nitric oxide synthase and some other inflammatory mediators caused ARDS. It's a pig lung. And you can see that 18 of PEEP was what maximally actually inflated that lung. And what's so important is that even with 5, 10, or 15 of PEEP, every time there was a breath taken, you had to re-recruit the alveoli. Now that is critically and profoundly important because we see that every day in critical care. So when we want to recruit the lung, there's a lot of terms that we use. When we want to recruit the lung, we use a mean airway pressure strategy. A mean airway pressure strategy means that you're going to get the mean pressure up. That's what keeps your lung open and maintains it open. And it's going to be applied for any patient who has low compliance, okay? Now remember, compliance is great. That's distendability. And patients who can't distend their lung are going to have high P plateaus. So high P plat typically means low compliance, not well distended. So lots of reasons for that to occur. Our purpose here today, just talking a little bit about ARDS. We're always going to consider that anybody who has an FiO2 of greater than 60% is really going to need some recruitment strategy with mean airway pressure. And I'm just going to remind you of the 3 basic strategies: increasing PEEP, pressure control inverse ratio ventilation, and airway pressure release ventilation. Those are commonly applied throughout the United States and the world. Now, the other one would be high frequency oscillation, but very few people are really well trained in that, and we don't do it that much. All right. Now, if your PIP is greater than 35 and you are using 10 or more of PEEP, you should really be thinking about mean airway pressure strategies. And always important to remember that when we instituted a lung protective strategy, that means a low tidal volume. So 4 to 6 mLs per kg tidal volume per body weight, per predicted body weight, but your patient is still not oxygenating, you're still having concerns about them, you really want to think about this recruitment strategy. So first and foremost, pressure control inverse ratio ventilation. That's historically quite common. Most people who've worked with critically ill patients and mechanical ventilation have seen pressure control inverse ratio ventilation. It's a common methodology for application. Sometimes people use another term for this, but pressure control inverse ratio ventilation means that I'm going to flow the gas into the lung at a very slow rate, and the target is pressure. So if the lung is tight, I'm going to flow gas in slowly, and that should ostensibly actually open the lung because it's applied over a long period of time. The problem with traditional pressure control inverse ratio ventilation is that the patient is not allowed to breathe. Right? This is not breathing. So we always need to be careful because on the vent, it'll say frequency, which we interpret as breaths per minute, but this is cycle time. Cycle time means I'm going to flow gas slowly, and then I'm going to allow for exhalation. But the patient is not able to breathe. They can't breathe during the high pressure time. They don't breathe during the low pressure time. And typically what happens is, so our normal breathing pattern, yours and mine, is in terms of fraction of the cycle of a respiratory cycle. So however many breaths you take per minute, let's say you take 12 breaths per minute, then that means each cycle is 5 seconds. So from a fractional perspective, typically you're breathing in for about 0.75 and your exhalation time actually completes that. So that would be 4.25. Okay. So normal I to E is inspiration is really short and exhalation time is really long. You're not exhaling that whole time, but you're resting. So and so I have a long rest time, and typically we're about 1 to 4. Now that changes when you're breathing more rapidly. But when we apply pressure control inverse ratio ventilation, we're going to start to flow the gas slowly, and we're going to increase the time spent in inspiration and reduce the time spent in exhalation. Now, first and foremost, you can say, well, yeah, that might recruit the lung, but now you're disallowing exhalation, so your patient may retain CO2, and you would be right. Okay, you would be right. That's really, really important. The other thing is that it can trap gas in the lung, and that gas could be CO2 rich. That's known as auto PEEP. Okay, now when we're on pressure control inverse ratio ventilation, that puts an extraordinary burden on the right ventricle, which always relies on those very aggressive pressure changes between inspiration and exhalation, and the prolonged time of exhalation, which allows the right ventricle to fill with volume. It's also profoundly uncomfortable. So almost universally, if you have patients on pressure control inverse ratio ventilation, they have to have neuromuscular paralysis applied. So as we all know, we're not really 100% in favor of that today in today's world, with all the evidence about what happens in terms of muscle dysfunction and myalgia and muscle wasting over time. So in general, we don't want to do it. Sometimes we have to, but we can actually see that we can have very significant barotrauma, very significant hypotension related to compression of the pulmonary vault and right ventricular overload. Okay, so you can just see that here is how we've set our pressure control. We've set the high pressure at around 36, where our patient's pressure was. And this is high pressure 36, and the low pressure here is around 10. So what actually happens is there's not a significant difference. I mean, you might think so, but really not a significant difference between high and low. And you have the possibility of trapping really what I would call dirty gas. That would be CO2 rich. And so oftentimes with pressure control inverse ratio ventilation, we're fighting battles with CO2 retention. Okay, so Very important. In this case, this is 2-to-1, but it can go up to 4-to-1. And what I want you to remember that if you have a patient on pressure control inverse ratio ventilation, you must paralyze them because they are not going to be able to breathe on pressure control inverse. If you're on true pressure control inverse, they won't be able to breathe. And they may entrap their CO2. And you may also see very significant diaphragmatic wasting because they're not making any diaphragm contraction. And so the diaphragm itself is a very proteinaceous organ and oftentimes gets wasted, particularly if the patient is critically ill, malnourished, and they're not using their diaphragm. Okay. It also, of course, puts a significant burden on the right heart. And remember, again, you have CO2 entrapment. That's what happens when you have auto PEEP, that all of the CO2 rich gas is not exhaled. So these are some really major problems. The most important one, from my point of view, the most important one is CO2 entrapment and right ventricular burden. But I also care significantly about diaphragmatic wasting, and it oftentimes in patients who stay on mechanical ventilation, even not on pressure control inverse, but just on mechanical ventilation for longer periods of time, they actually lose some of their diaphragmatic function, and it becomes very difficult to wean them off the ventilator. Okay, so now we're going to talk about airway pressure release ventilation, which is a beautiful marriage. And it's really important to appreciate a beautiful marriage of spontaneous breathing and pressure control. How did that happen? That's what this is. So in your mind, just appreciate your patient is going to breathe spontaneously, but he's only going to make small efforts for breathing. He's only going to move about 1.5 mLs per kilogram. But what we're going to do is we're going to open his lung. So some folks say it's the marriage of pressure control inverse and SIMV. Unfortunately, I think that leads you down the wrong path. So we're going to refer to it in a particular way in just 1 second. What I want you to appreciate, airway pressure release ventilation, when it's properly applied, lots of people say he's on APRV. You look at the ventilator. No, he's not. He's on pressure control inverse. Because the really important perspective here is that your patient is breathing. He is breathing spontaneously, but he will only breathe spontaneously during high time, meaning high pressure, high time. That high pressure is applied CPAP. So we're going to apply a continuous positive airway pressure at the level that we saw his P plateau was, or his mean airway pressure plus 2 to 4. We're going to apply that pressure like CPAP to actually open the lung, and then we're going to allow the patient to breathe spontaneously above that. Now that sounds complicated. When we look at some graphics, it won't seem complicated at all. It's beautiful. So just think about, first start with CPAP. We're going to apply a CPAP at around 30 centimeters of water pressure. And we're going to apply it for around 6 seconds of time. And we're going to allow our patient to take small breaths with pressure support too, across that high pressure and high time, because that continuous positive airway pressure has opened the lung. And now the patient has to breathe just like a little hummingbird. The reason he has to breathe is because the only way to get CO2 up into the higher airways is through his spontaneous breathing. That is a really important perspective, because allowing your patient to breathe spontaneously across high pressure time moves the CO2 up into the airway, and then we're going to release the pressure, and we're going to release the pressure down to 0. So you're going to go from 30 to 0, but only for about 0.8 seconds, which is almost like sucking that CO2 out of the airway. It's a Windkessel effect. It is fantastic when it's applied correctly and in the right patient. Fantastic. Spontaneous breaths allowed, only during high time. No breathing during low time. Well, very, very important to appreciate. We're going to set high pressure based on your P plateau or your mean airway pressure. We're not going to paralyze you, and we are not going to over sedate you. all we really want to do is prevent you from being anxious, but we need you to breathe, and you need to breathe across high time. So now I want to give you a visual here. So what you're looking at here is, you see that green going up and it's constant across here, and then that yellow going down. This is your high pressure cycle time. And you can see here that your high pressure cycle time is just a little bit over 5 seconds. So we apply that continuous positive airway pressure for about 5 seconds, and then we release that flow of gas. So your pressure drops down to 0. You can see that close to 0. It might be at around 2. So I'm applying continuous positive airway pressure, and I'm at a little bit above 30, around 33. And then I release it for less than a second, 0.8 seconds, all the way down to 0. So what happens here is my patient is breathing spontaneously with pressure support across that high pressure time. And every one of these small breaths is actually mobilizing carbon dioxide up into the airways. So when I release the pressure, and that means there's no longer flow of gas into the lung, I stop that flow, that releases that pressure, and CO2 is sucked out of the patient. Your patient is oxygenated by high time and high pressure, and his CO2 is removed based on the difference between high pressure and low pressure. And you don't need very much time for that to occur. And you don't want to allow much time for that, because if you allow more than 0.8 seconds or 1 second at the max, although 0.8 is what is recommended, your patient is going to de-recruit his lung. So you have to prevent him from de-recruitment at the same time that you're helping him to wash out his CO2. So this is the pressure in the circuit. Here's the volume mobilization in the circuit. You can see this is a tiny amount of volume that's being moved, but that's what gets that CO2 up into the main airways. So when you release the pressure, you can exhale your CO2. Now, this patient also has, this is a basic volume breath that he received here as well. Okay, so really important to appreciate behind APRV, the single most important issue is that, not the single most, but one of the most important issues is that rapid release of flow, which means that the pressure, which was high, now drops down to 0. And that gives us this beautiful Wynne-Kessel effect on the CO2 that helps us to mobilize our CO2 really effectively. High pressure, long high time, that's what you're looking at here. So this is 5 seconds, and the pressure is somewhere around 32 or 33. High pressure, 32. All that means is it's a high Cpap, right? It's just positive pressure. It's related to flow of gas into the lung. High pressure and long high time affects oxygenation. And the short low time, that's that release time, short release time, low time, prevents de-recruitment. Very important in terms of understanding what's occurring when we talk about APRV. Now, the difference between the numeric high pressure and the low pressure is very much like what we talk about with IPAP and EPAP. The differences between high and low pressure is what really promotes that CO2 removal. So at the higher pressure, I'm trapping gas in the lung, and when I release the pressure, all that gas flows out. And we only allow that to happen for a very short period of time because we don't want the lung to become de-recruited. So now, I think we already understand this, the terminology, and there's really 4 things we have to appreciate. P high, which is the baseline airway pressure level. That's the continuous opening pressure, also known as CPAP. And on your ventilators, it might be called high PEEP or PEEP high, but you're not talking about positive pressure on exhalation. You're talking about prolonged positive pressure. So the better term, even if your vent says high PEEP, is to say high pressure, high time, high pressure. P low is the airway pressure that results when we release the flow. That's the airway release, and that's what creates that Wynne-Kessel effect for CO2 removal. So typically your P high is going to be set right around your plateau pressure or your mean airway pressure plus 2 to 4. And your P low is going to be set right around 0. Sometimes our physicians are very uncomfortable, especially if they're not pulmonologists. They're like, I don't want to drop down to 0. I want to keep it at 8. But actually keeping it at 8 actually is completely in opposition of what you're really trying to achieve, which is this big gradient between high and low, and using it at a short time, which prevents de-recruitment. The time for high is the length of time that P high is maintained. The time for low, or also they may call it PEEP, that's the time spent in airway release. So that's really P low. So how I like to talk about it is P high, P low, time high, time low, not time low. Okay, so just really, really, really important to appreciate that what we're doing is we're just opening your alveoli, and that constant flow of gas, which then exerts a pressure, maintains alveolar opening and enhances gas mobility and gas diffusion. That long time, so not just the high pressure, but the long time allows time to recruit alveoli. Some alveoli are fast responders, others are slow responders. We're not going to make a decision about whether APRV works or not until we're about 12 hours in, because it's going to take time for those alveoli with slow time constants to open up. Okay, very, very important. And these releases of, I've opened your alveoli and now I'm releasing the flow with very short time, actually prevent you from what's known as repetitive opening injury. For most of the time, the way we breathe is alveoli collapse, we reopen, alveoli collapse, we reopen. And when we've got somebody who's already got lung dysfunction, that process can actually make that lung injury much, much worse. So this is how it works. P high is the high pressure level. T high is the time spent on high pressure. P low is the low pressure level or the release. And T low is the time spent at release level. Those are the four things that are important when we're talking about APRV. So we remember we're going to set P high based on your P plateau or your mean airway pressure plus 2 to 4. And we're going to set T high typically between 5 to 6 seconds. We're going to set P low if everybody is cool and they really understand what we're trying to do. We're going to set P low at 0. And really 0 to 5, typically never greater than 5, and really optimally at 0. And we're going to set T low at 0.8 seconds or less. So we're not going to allow time for the alveoli to de-recruit. Okay, so now you're going to look at this, just this visual, which is the T high with the spontaneous breathing, and then the T low, and it's very short, that T low. This is just an artist's rendition, right? So here we are at P high, T high, time high, pressure high, patients breathing spontaneously, cannot breathe at P low or T low, not allowed to do that. And they're not going to because there's not enough time for them to do it. Okay, so what we're really doing here is with that P low and the T low is preventing the alveoli from collapsing. And with the P high, we are spending a lot of time opening the alveoli at that high pressure, but that protects us from over distension. It's really fantastic. Now, there's a lot of advantages, I mentioned just now the repetitious reopening of alveoli, which is very injurious in critical patients. We've obviated that. We're not going to have that problem. And now what we're going to do is we're going to use a very low tidal volume, because the patient's breathing on his own. He might breathe 1.5 or 2 or 3 mLs per kg, but instead of wasting 3/4 of his breath trying to get the alveoli open, the alveoli are completely open. So little breaths actually communicate directly into the alveoli. And this will significantly and profoundly, if it's working, and if we've done it the correct way, will significantly, profoundly improve oxygenation. So again, it's really, really important to appreciate the alveoli is open for 6 seconds. It's released for less than 1 second, and the open close possibility is no greater than 8 times per minute. But in reality, you are actually generating auto PEEP for these patients. So you really should not have that kind of trauma to the lung, because it shouldn't really be opening and closing at the alveolar level. Okay, so again, we're going to select what I'm going to call CPAP. Our vents call it high PEEP. Okay, they call it high PEEP. but it's not PEEP, it's a continuous pressure. So I'm going to select that Cpap level. It's known by our vent as PEEP high. And I'm going to set that release time or the rate at 0.8 seconds and the duration of, so I'm going to set the number at around 0 and the release time at less than 1 second. And I'm going to think about increasing that repetition if I have to reduce CO2. Okay, so traditionally, we've got a patient on a conventional ventilator. So we're looking at what his mean airway pressure is in a pressure cycled mode, or we can look at plateau pressure in a volume mode. And remember, if we do mean airway pressure in a pressure cycle, so they're on pressure controlled ventilation, we're going to add 2 to 4 to that mean airway pressure. And that's what we're going to do when we transition from conventional. Low PEEP, which is low, the low pressure and the low time. So low PEEP, 0 to 5 centimeters of water pressure. So I don't know if anybody's on here from surgical ICU, but I'm just going to mention to you that a lot of times in the surgical ICU, we use a much higher low PEEP, and that actually prevents you from really being able to achieve the maximal recruitment. T high, 4 to 6 seconds, T low, 0.6 to 0.8. This is what you do when you transition from conventional ventilation. Okay, so now we're going to take a look at my patient. That's not the patient we talked about in the beginning, but one of our patients who was in our surgical ICU. And this was so beautiful. So you can see that he's got 10 cycles a minute. It's called bilevel because that's the brand name. And his high positive pressure, which I would call high Cpap, is 28. And his time for low is 0.83. And he's set at 0. Okay, so this is high pressure, low pressure, and low time. Okay, now, so low time is set and everything that's not low time based on the cycle. So we're doing 10 cycles per minute and each low cycle is 0.83 seconds. All the rest of that is spent in high time. And you can see that high time, release, high time, release, high pressure, low, high pressure, low. And you can see your patient is breathing spontaneously, okay? And that is so fantastic, okay? Now, what I want you to see is his mean airway pressure, 24 plus 4 yields that pressure that I'm using to open his lungs. And I've set his cycle time at 10, but he's breathing 30 times a minute. And he's moving a fair amount of tidal volume. Now, this is from his cycle time. The rest of the time, you're going to see his tidal volumes are 105, 90, 120, because remember, he's taking very small amounts of volume with his breath. This is actually looking at the difference between high pressure and low pressure. And we are going to address that if our patient is retaining CO2. So this is what I want you to appreciate and understand. This is how your breaths work, right? When we use APRV, instead of having all of that derecruited alveoli, we open all your alveoli and you can see that they're open and then you have just the smallest amount of jiggle. And that really is your patient's spontaneous breath. And over time, it's not going to happen immediately. You have to give them some time. They're going to open all of their alveolar compartments, which means they're going to have much more opportunity for gas exchange. So you can see that they're opening their alveolar compartments here. It's a really fantastic strategy that really helps us significantly when we're talking about managing patients. So similar to that. So this is a patient now whose lung is open, and what you're seeing is very small amounts of volume in the spontaneous breaths of that patient. Okay, so if your patient needs to have better oxygenation, you of course can increase their FiO2. You can also increase the mean airway pressure. That just like with CPAP, I'm going to increase the P high and I'm going to increase the T high. Okay, pretty straightforward. FiO2, P high, T high. That's what's going to open the lung. That's what's going to allow me to oxygenate significantly. Okay, so this is really, really important. P load doesn't really affect in APRV, unlike spontaneous breathing, where you're talking about PEEP and you're talking about applying PEEP to improve oxygenation. Here, you are applying CPAP, high pressure, high time, And that low pressure is not about oxygenation here. It's actually about creating the difference, which promotes that Wind-Kessel effect and CO2 removal. Okay, so T high is the most important component for opening the lungs. So we're going to continue to increase T high, but the longer T high is, then the less time you're going to have for CO2 removal. So you're always going to be careful when you're evaluating your patient and monitoring them and working with the changes that your docs are applying. If you want to increase ventilation, which is the CO2 removal, you're going to increase your P high. That will improve the difference between P high and P low is what's going to affect the tidal volume. And we saw that on our patient. He had a tidal volume of 880 because of the difference between high and low. Okay. Now, the other thing is that you may have to reduce your time spent at high so that you're going to have more releases, and that should clear more CO2. So that's all really good. The most important control setting for CO2 is the difference between P high and P low. So I know there were some folks on here, they may not be here anymore, but some folks even from our step down unit. This is the same concept of BiPAP. So IPAP minus EPAP affects tidal volume. P high minus P low affects your tidal volume. And that will really help you to clear your CO2. But the most important thing is to optimize spontaneous breathing, which means you can't flip out. Your patient's breathing 30, 40, 50 times a minute. That's okay. It's small breaths. Don't flip out. Don't add sedation. Just really, if possible, calm, comfort, and Precedex. This is what Precedex was designed for, to actually create anti-anxiety without sedation. So now we just take a look at the 3 different categories that have some similar terminology. Here's inverse ratio ventilation, a prolonged inspiratory time and a shorter exhalation time, but patients not allowed to breathe. Then we go here, I'm going to go over here to BiPAP, which is high pressure and low pressure, and your patient breathes at the high time and at the low time. And then APRV, patient can only breathe during high time. That means every little breath they take is not wasted because gas is going directly into the alveolus with a very short release time, which actually allows them to release their carbon dioxide. So lots and lots of advantages here. And I think I've really covered the majority of them. I just want to go over really quickly initial settings and the way that we look at settings. And your respiratory therapist may do things differently, but generally what we say is we're going to put you on P high according to what your PF was, according to what your mean airway pressure was, or according to what your P plateau was. So you can see we're going to apply a fairly high mean airway pressure. Typically, we don't like to start at greater than 30, but we will go up to 35. I've never done it any higher than 35 centimeters of pressure. And typically we start around between 28 and 30. Okay. Remember that we like to look at high time at around 6 seconds and low time at around 0.5 or 0.6 seconds. And that can really help us in terms of recruitment of the lung, promoting oxygenation as well as CO2 removal. And we go back to our man. And our man, we put him on a high pressure 30 with a high second 6, low pressure 0, low time 0.8. After 2 days, we were able to drop his high pressure and stretch his high time. Drop his high pressure and stretch his high time until you actually have converted to Cpap. And that's Cpap with basically a Cpap with the patient spontaneously breathing. And this is really how you wean APRV. On post-op day 12, he moved to the floor. And that was a really successful time for us and a really, really important. And I'm so sorry because the one slide I wanted to make sure that we had that we didn't have here, which is pay attention to that high time and that high pressure. Remember, that's what you're going to use to recruit oxygenation. Don't get disturbed or distressed if your patient is breathing small tidal volume breaths 50, 60, 70 times a minute, because they can do that. As long as they seem comfortable and not agitated, you're going to use Precedex and anti-anxiety agents rather than sedation agents. A lot of whether or not APRV works is actually dependent on how we approach it. And I think that's so incredibly important when we're talking about maximizing ventilator support. We might not be the people making the changes. We're not making necessarily the decisions. Even as APPs, we'd be really discussing APRV with our attending physicians. But I think very, very important to recognize that a lot of what we do at the bedside actually determines how we're going to apply these strategies. And it is really important to say that I might start with you sedated, but then I'm going to wean your sedation, because the best advantage in APRV is to have a patient who is actually breathing on his own across that high time and high pressure, so that every little breath they take actually reaches the alveolus and promotes better gas exchange. I thank you so very much. And for those of you who are new, just remember, I'm going to stop recording, but I am still going to be available for questions and discussion. So thank you very much. And thank you for joining today.